Today, we're moving from theory into application. We've already talked about reliability, validity, ethics, and understanding scores. Now we're getting into what counselors actually do with assessments in real world practice. Because here's the thing, most counseling assessment work is not dramatic psychological testing scenes from the movies. It's usually a lot more quieter than that. It's about choosing the right tool, deciding whether a tool even fits the client, noticing when results don't match the person in front of you, and figuring out how to communicate information in a way that actually helps somebody. A good counselor does not blindly trust a score. A good counselor interprets scores in context. So sometimes students imagine assessment as this totally separate thing from counseling, but in reality, assessment is woven throughout the counseling process. Counselors use assessments to identify symptoms, monitor change, better understand client functioning, and support decision making. So, for example, a PHQ-9 might help track depression symptoms over time. A substance use screener may help determine a level of care, and a career inventory might help a client reconnect with identity after burnout. But assessments are tools, they are not replacements for clinical judgment. Think of it like GPS navigation. GPS can help orient you, but if the bridge is out and the GPS keeps telling you to drive into the river, hopefully you override it. Counselors have to do the same thing sometimes. We live in a culture obsessed with categorizing people. Social media loves personality quizzes. Which Taylor Swift era are you? What kind of anxious attachment are you? What mental disorder matches your coffee order? And honestly, some people walk into counseling expecting assessment to work exactly like that. But ethical assessment is much more thoughtful. Just because an assessment exists does not mean it's valid, appropriate, culturally responsive, or clinically useful. A counselor should always ask, what problem am I trying to solve by using this tool? Because sometimes counselors overassess when what the client actually needs is human connection, stabilization, or safety. So choosing an assessment is a lot like choosing tools from a toolbox. You would not use a hammer to tighten a screw. In the same way, counselors should not use trauma screeners for personality diagnosis, personality measures for ADHD assessment, or reading heavy tools with clients who struggle with literacy. You have to also ask, who is this normed on? Historically, many assessments were standardized primarily on white, English speaking populations, and that matters. If a test was not designed with your client population in mind, interpretation becomes much riskier. Assessment isn't just about psychometrics, it's also about fit. So, one of the biggest mistakes new counselors make is treating assessment scores as objective reality instead of pieces of information. A depression score might be elevated because somebody is grieving, or exhausted, or hungry, or in chronic pain, or unsafe at home, or actively traumatized. And that does not automatically mean major depressive disorder. This is where counseling becomes interpretive work. A test score without context is kind of like reading one page of a novel and assuming you know the entire story. The way an assessment is administered changes the experience of the assessment itself. So think about the difference between filling out a trauma inventory alone at 2 a.m. versus completing it with a supportive counselor present. Same assessment, very different experience. COVID also changed assessment practices dramatically. Telehealth assessments became much more common. And that introduced new variables like distractions or privacy concerns or internet problems and reduced behavioral observation. Counselors now have to think not only about what tool they use, but how the environment changes the data. So preparation matters more than we often realize. Clients notice when counselors seem uncertain or disorganized. Before administering an assessment, counselors should know the instructions, understand the scoring, anticipate client questions, and create an environment that supports concentration and safety. Test anxiety is real, and some clients associate assessment with failure, school trauma, psychiatric hospitalization, or judgment. Even something as simple as saying, there are no perfect answers here, can lower anxiety significantly. An assessment is not passive. Counselors are observing the entire time. So, for example, we want to pay attention to if the client is rushing or becoming frustrated or dissociating, or maybe asking for repeated clarification, or maybe even avoiding certain items. Those observations are going to matter. Imagine somebody completing a trauma inventory while visibly shaking and skipping entire sections. That information is clinically important even before scoring happens. The assessment process itself can tell you a lot. And then once the assessment is completed, counselors move into interpretation. And interpretation is where a lot of ethical problems can happen. Some assessments include validity indicators specifically because people underreport, overreport, random respond, or misunderstand items. For example, on the MMPI, clinicians first look at whether the profile is even valid before interpreting the scales themselves. And that surprises a lot of people, but it reinforces an important idea. Assessment data is human data, and humans are messy. So assessment scores do not exist in a vacuum, and I know we've talked about this before. A client who slept 2 hours the night before, maybe got into a fight before the session, and fears being hospitalized may answer very differently than somebody who feels calm and safe. Think of scores like a photograph. Photos can capture something real, but they also freeze a moment, miss context, and depend a lot on angle and lighting. An assessment works similarly. Computer generated reports can absolutely be helpful, and importantly, computer generated assessment reports are not new. Counselors and psychologists have been using computerized scoring systems for decades. For example, the Minnesota Multiphasic Personality Inventory, or that MMPI that I keep talking about, or the Million Clinical Multi-Axel Inventory, or the Strong Interest Inventory, even the Myers-Briggs type indicator. Many career assessments use computer-based scoring and often generate automated narrative reports after scoring. Those reports can summarize elevated scales, personality patterns, symptom clusters, career themes, or even possible diagnostic considerations. So, computerized interpretation itself is not inherently unethical or unusual, but there's an important distinction between traditional computer generated reports and modern AI systems. Traditional assessment software is usually rule based, meaning if somebody scores within a certain range, the software pulls from the pre written interpretive language connected to research and norm data. It's structured, predictable, and limited. AI is different. AI systems generate language dynamically and probabilistically. They are predicting what language fits based on patterns from massive data sets. That means that AI can sound incredibly insightful, emotionally intelligent, and confident, even when it's wrong. And that's where things get slippery in counseling, because counseling students and even experienced clinicians can start mistaking fluent language for clinical accuracy. And that's really dangerous. A traditional MMPI report might say something like, elevated scores on scale 2 may indicate depressive symptoms, including hopelessness and low mood. An AI system might generate an entire beautifully written conceptualization that sounds meaningful while quietly missing trauma, over pathologizing culture, reinforcing bias, hallucinating conclusions, or even flattening context. And if the clinician is not thinking critically, the AI language can begin shaping the clinician's perception of the client, and that is a huge risk, especially because assessment interpretation is already vulnerable to confirmation bias. If an AI narrative says, client demonstrates borderline personality features, a clinician may unconsciously start filtering future interactions through that lens, even if the formulation is incomplete or inaccurate. And we're already starting to see this culturally. Pop Psychology Online increasingly treats symptom checklists, algorithmic suggestions, and diagnostic language as identity categories instead of tentative clinical formulations. Now, to be fair, there are also potential benefits. AI could potentially help with reducing administrative burden, identifying scoring inconsistencies, organizing large data sets, improving accessibility, translating reports into simpler language, generating drafts, or helping clinicians notice patterns that they may have missed. For overwhelmed systems, that's appealing. But AI still cannot truly contextualize human experience. It cannot sit with contradiction. It cannot recognize masking, sarcasm, dissociation, relational dynamics, cultural nuance, or the emotional atmosphere in the room. It also cannot ethically hold responsibility. The counselor still carries that responsibility. Even healthcare organizations are now warning providers that AI-generated documentation can create inaccuracies, HIPAA or privacy violations, fraud concerns, and clinically misleading documentation if clinicians rely on it too heavily. And honestly, I think that one of the biggest dangers is subtle de-skilling. If clinicians stop actively conceptualizing because AI does it for them, over time they may lose some of the very clinical reasoning abilities that they're supposed to be developing. Counseling is not just pattern recognition. It is relational interpretation, and that is different. Technology can absolutely assist assessment, but once counselors begin outsourcing critical thinking or ethical judgment or conceptualization or human presence, we've crossed into something very different from counseling. So good reports should sound like they were written by a human being, not a malfunctioning appliance. So compare these. Client demonstrates manipulative tendencies versus client appears to use reassurance-seeking behaviors during periods of emotional distress. One path stigmatizes and the other attempts to understand. Counselors should always ask, if my client read this report, would they feel understood? So let's end with just a short case example. Jordan is 19 and comes in reporting poor concentration, difficulty completing assignments, emotional dysregulation, and feeling mentally checked out. A parent believes that Jordan has ADHD, but Jordan is also sleeping 4 hours a night, using cannabis daily, recently experienced trauma, and reporting significant anxiety symptoms. So here's the question. What would you assess first? Would you jump directly into ADHD testing? Or would you slow down and consider trauma, anxiety, sleep deprivation, substance use, and emotional stress? And that's the work of ethical assessment, not just identifying symptoms, but understanding context.